Grant. So welcome to this Q call. And since today we have heaps of panelists in this call, I think I'm just going to go straight away and give the word to Natalie, who used to be in the Q team and now came back as a member. It's such a pleasure to have you here. Natalie, please.
Thank you, Joriam, and thank you everybody for joining us today. So my name's Natalie. Yes, I'm a Q member, so I'm part of the Q posse and ex kind of Health Foundation employee. So it's kind of, for those of you who are from either Q or the Health Foundation, great to connect with you all. And similarly, for those of you that I don't know, it's again great to share space with you this afternoon. So I'm super excited to share with you the work that we have been doing in partnership with UPD, the Understanding Patient Data team at the Wellcome. So we were interested in terms of looking at how we address the health data gap for Black and South Asian people. And I will pass you over to Emily, who is the engagement and strategy engagement manager at UPD, who will provide you with some background to the work that we are doing. So I will hand over to Emily.
Thank you, Natalie. So this part will be from myself and my job share partner, Rebecca Asher. So I'm Emily Jespermere. We work in Understanding Patient Data, which is hosted by the Wellcome Trust, and we also sit in the Wellcome Trust's digital equity team. And you'll hear from Rebecca Asher shortly. So who are Understanding Patient Data? I know some of you know us well. I've seen someone here from Use My Data and Ada Lovelace, but other people maybe less so. So we aim to make the way patient data is used more visible, understandable and trustworthy for patients, the public, for health professionals. We bring transparency, accountability and public involvement to the way that patient data is used. And so what was our motivation for this public-led equitable data collection project? Well, we wanted to learn more about the views of Black and South Asian people because of the health disparities they experience, which was starkly highlighted in the mortality rates from COVID-19. Research into health outcomes during the pandemic had also exposed the frequent gaps in patient health records on ethnicity, as well as important clinical information and social determinants of health. This resulted in a new policy focus on completing ethnicity in patient records. But we thought it unrealistic to expect lasting change without examining the reasons behind that. So we wanted to understand what was happening on the ground that meant data wasn't being collected by hearing from Black and South Asian members of the public and healthcare staff about their experiences and views of health data collection. We also wanted to produce practical resources that might help improve the situation.
Thanks, Emily. So ahead of the work by Liberating Knowledge, which we're focusing on today, there was a previous first stage conducted by Clearview Research. And I think that some of the team from Clearview Research might be here today. And if so, great to have you with us. So in that first phase, Clearview carried out engagement with Black and South Asian members of the public. And this involved peer-to-peer research and focus groups. And their report is available on the UPD website. Among their findings, they found that people believe that data can be used to improve health outcomes in their communities, but they do not see this at the moment happening in reality. And people want to be informed about how their data is influencing research, design and planning of healthcare services and have the opportunity to shape those plans themselves. The insights from this engagement directly inform the public survey questions, engagements with health staff, and co-created resources we're launching with Liberating Knowledge today. And we want to thank very much Clearview and Liberating Knowledge, the participants who took part in the research, and our fantastic advisory group who've been involved in this project, including Professor Winston Morgan, who is on the panel today. And so I'll hand over now to Natalie again to share the findings of the research.
Thank you, Emily and Rebecca. I'll now pass you over to my colleague, Daphne, who will be providing you an overview of some of the highlights that have come through the research that we have been doing with healthcare workers and with the general public through a survey. Daphne.
Thanks, Natalie. Hi, everyone. I'm Daphne Mavenus. I'm also past Health Foundation staff. Wasn't in the Q team, but worked closely with them. So nice to be back again with the community. As Natalie said, I'll share the findings from the work that we've been doing in partnership with Understanding Patient Data. So we have been building on the insights from the work that Rebecca spoke to, delivered by Clearview Research. We had a two-part approach to the work that we're doing. So first, seeking to understand the views of healthcare workers on where they feel why they feel there's less complete patient data for those who are from Black and South Asian backgrounds. We also wanted to understand their thoughts on barriers that are hindering good data practice and any solutions they might be aware of, and what their aspirations are for how to improve things going forward. The second part of the work was a survey with the public, seeking to really build and explore on the themes that emerged from Clearview's research, as we were conducting that at greater scale, and understand the measure to the extent to which the views surfaced in that initial research were shared more broadly amongst Black and South Asian communities. So with the engagement with healthcare workers, we conducted 5 focus groups and 7 interviews with 37 different members of the Health and Care Service. And we found some really interesting insights. The first is that we heard there's a real lack of confidence in describing the purpose and use of data where it's not something that's used regularly in the roles of the workers involved. So if they're not a data analyst, basically, they weren't very comfortable with explaining how data is used. The common resource and time pressures that we're very aware of for the NHS staff really impacted their ability to prioritise data collection and have good conversation with patients about their data. Some staff talked about the lack of people in leadership roles who are really committed to tackling bullying, institutional racism and health inequalities, and lack of leadership of those from Black and South Asian communities, and that then acted as a barrier. And there were concerns expressed about how trustworthy is the NHS from staff members who are Black and South Asian, given past harms. So these quotes just bring to life some of the points raised. So we have an anaesthetist from a South Asian British female background who shared that she thinks, well, maybe those that are making the decisions aren't necessarily directly impacted. So maybe the answers to the questions don't really matter to them. And from a service manager who didn't feel comfortable to disclose ethnicity and sex, they share that they fear discrimination, and that echoes the point about concerns about trustworthiness from healthcare workers who are from minoritized backgrounds. Then we also heard that there are mixed views on whether staff believe that Black and South Asian communities are supposedly hard to reach. Some agreed with this, while others shared that actually they had really positive experiences where investing time to build that trust led to good engagement. Those from minoritized ethnic backgrounds were more likely to understand the importance of being represented in data to support efforts to tackle health inequalities. But somewhat concerningly, some suggested health inequalities were a consequence of individual level and biological factors, rather than recognizing the structural inequalities that exist in our healthcare system and wider society. A lot of staff, they shared a common desire for the NHS to be more ambitious about how it approaches improvement in collection of data. And there were some quite innovative ideas shared, such as giving more control to people and communities over their data, the insights generated from them. So again, we have some quotes to support our findings. A clinician researcher shared that we must lean on the people in the communities who are well respected and who people do listen to, suggesting that we work in partnership with BCS organisations. And a psychologist shared that they think one of the key advantages of collecting data is making services more equitable for all. So moving on to the survey, we engaged all 3,273 people participated in our survey from a wide range of backgrounds, so from multiple ethnicities, and we had good representation from Black and South Asian communities who we wanted to speak to, but we did notice smaller responses from certain minoritized groups, which limited how far we could go with our analysis. But what we did find is that there are really high levels of engagement of those who participated, which is somewhat to be expected given they were willing to complete the survey. Respondents from all backgrounds trusted the NHS with their personal data. We did see that people from all ethnicities had similar levels of engagement with health information and also similar willingness to share their personal data. We saw that only 1 in 5 respondents had a conversation with a healthcare worker about how their data is used, which is quite concerning as such a small proportion. And where they did have the conversation, it did increase people's willingness to share their personal data and help them to have a broader understanding of its use. We noted somewhat of a contradictory experience where Black and South Asian respondents have both greater concern about the impact of discrimination against them, but also express greater hope that sharing data can reduce likelihood of discrimination, which is interesting to see both of these things come through. And we saw that most respondents want to learn about how health data is used ahead of their consultations in written formats, ideally, or as a conversation. So moving on to our reflections, we found that there is no kind of different experience or different level of comfort sharing personal data from Black and South Asian communities compared to white communities in particular. There were high levels of engagement, and that showed that there isn't necessarily a lack of interest or engagement from Black and South Asian communities, which is commonly reported. And this really ties into the findings from the Clearview research, Diverse Voices and Data, that show that Black and South Asian communities are willing and interested in sharing their data. We think that we need to really challenge this narrative of hard to reach communities and people hiding behind this. In hiding behind this, it does push the responsibility to take action with minoritized groups rather than the NHS taking on this responsibility. And this really links into thinking also about the role of trust. So lack of trust is often cited as an issue and something that influences the willingness of Black and South Asian communities to share their data. And we really need to reflect on what kind of power dynamic this leads to and think about how we can shift this between institutions and communities. We think it's for the NHS to think about how to demonstrate that they are trustworthy to communities and really move away from locating the issue of distrust within Black and South Asian communities. In doing so, we think this could lead to better relationships and opportunities to work collaboratively to tackle health inequalities. Through the work we did see that it came across that the burden of tackling health inequalities rests on those with lived experience. So we had challenges in engaging white people in this work with significant time required to recruit sufficient healthcare workers who are white to the focus groups. We also saw in the survey that there was less concern for potential discrimination for minoritized ethnic communities by white respondents as compared to others. And we also had the remark from healthcare workers in the focus group who observed that there's less engagement from senior leaders who aren't from minoritized backgrounds in tackling health inequalities. So to really make that progress to tackle health inequalities, we need to see that all staff see addressing health inequalities as their responsibility, particularly those who are influential and senior decision makers. Now really is the time to make sure staff have the skills, the knowledge, and are equipped to close the gap in patient data. They need to understand why it's important to have complete data and the potential benefits. And given the positive impact of having a conversation, we really need to make space to ensure that more of these conversations can happen between healthcare workers and patients about how data is used. It's important to share with communities also how data collected from them is used to avoid having an extractive relationship where they share information but no benefit is necessarily seen. So in terms of the recommendations that we set out, we've got 11 targeting people working in the health and care system. And the first is really to think about creating an enabling environment for these recommendations to be delivered by accelerating any efforts to eradicate racism within the NHS. We think that it's worth thinking about developing a race equity framework for physical health services, and this can draw on the experience of developing the patient and carer race equality framework in mental health services. We want to see there being support and commitment of senior leaders across the board to improve data practices and really embed inequalities work, supporting their staff to create the space to innovate within the NHS. We want to see the hard to reach narratives being challenged. Healthcare workers really need to be given the tools to hold meaningful conversations about data. And there needs to be regular sharing of learning about equalities work with all aspects of the system. So community members, healthcare workers, wider professional and scientific community. We want to see there being meaningful engagement with Black and Asian-led BCSE organisations to ensure that the opportunities to collaborate are really maximised. We want to see there being system-wide protocols developed to routinely collect equalities data and ensure disaggregated and analysed from an intersectional approach. And we want to see there be in partnership with the Unified Information Standard for Protected Characteristics team, who can really lead on expanding the ethnicity categories with those from racially minoritized communities. We want to see more research that takes an intersectional approach, so to think about minoritized experience of those within Black and South Asian communities. And we want to see that an anti-racist approach is really embedded in data collection, analysis, dissemination, and its usage as well. So I'll pause there and hand over to Natalie, and we can broaden out for a panel discussion.
Brilliant. Thank you so much, Daphne, for sort of sharing an overview of the work that we've been doing. So we will be going out to hold some kind of, there'll be a Q&A session in a moment. But before we do that, I'd like to have a conversation with a few panel members. So we have a few experts that we would like to have them share their views and perspectives on the report. So I'd like to start first with Professor Winston Morgan. I wonder if you could introduce yourself to the group. But I'd be really interested in your thoughts on the report, and particularly interested on any reflections you have in particular around staff knowledge of the root causes of health inequality and beliefs around there being an individual and biological basis for inequalities.
Right, thanks, Natalie. Thanks everyone for this report. It's really comprehensive, really lots in it, and I'm still learning a lot of the just what people have to say, both the staff as well as the people who took part in the survey. So thank you very much. Sorry, I'm Professor Winston Morgan, Professor of Toxicology and Inclusive Practice. And in terms of this discussion, my interest is in around health inequalities linked to race. In terms of my observations, what I would say is that having comprehensive data on specific patient groups will contribute to how these patients are treated by health service professionals to their benefit. So the understanding patient data projects are really welcome, really important that we have lots of data. But I have to say we must not overstate the idea that missing data from certain patient groups is the main driver of health inequalities. So yes, the data is important, but it's not the only or the main reason why we have health inequalities. Because even where the data is available, I think it's more about direct and indirect discrimination by health service staff, not necessarily, sometimes unknowing, but sometimes knowing, and it's based on perceptions about particular groups. And that's one of the most important things in terms of why we see this kind of discrimination. So if better data, more comprehensive data can be made available, it might actually highlight some of the structural issues, because a lot of these inequalities are around structure rather than biology, as I'll mention a bit later. So if we can highlight them and say they're structural, why these groups are affected and not others, then it's going to be really, really important. So this data will also help to combat misconceptions about biology and genetics linked to health outcomes. People are generally categorized, as we know, from these databases by race or ethnicity or both. And these are both social constructs or categorization. So when you talk about someone's race or ethnicity, there's no science, there's no biology in it. It's a social thing. There are small differences that we'll see in terms of disease outcomes. I won't go on too long between different human groups, but they tend to be linked to populations rather than race or ethnicity. However, the temptation is always to find a biological difference. Then we do not have to consider structural differences or discrimination in why people aren't being served properly. And I can see why some health professionals want to do that. And we saw this particularly during the COVID-19 pandemic, when senior doctors and sort of like and scientists, they could not rule out race as if you like, or ethnicity as some kind of a factor in terms of biology, why people were being affected, although they knew deep down it wasn't. So these are just some of the things that we have to get over. And I think having better data, more accessible data, will help to deconstruct some of these misconceptions about different groups of people, because generally we're all humans, and there are very few conditions where your race will actually make a difference in terms of biology, in terms of outcomes.
Thank you so much for that, Winston. I think you highlight a really important point around that. Yes, it's important for us to collect the data so that we can be seen, but essentially that's not going to be the fundamental driver in terms of narrowing the inequalities gap. So it's a small part in the overall picture, but actually in doing that, we do need to make sure that we are paying due attention to the structural factors that are shaping people's health outcomes. And so I just wanted to follow on kind of on that thread of the data and kind of being able to be seen in the data. And I suppose hear your thoughts, Rima, around what do we really need to be thinking about in terms of, or keeping at the forefront of our minds when we're thinking about reducing the data gaps for Black and South Asian communities?
I wanted to pick up on Professor Morgan's point about the missing data problem not being the only driver of health inequalities. I think it's a really important point. So just to reinforce that, but also expand upon that further. So it's not the main driver. In fact, I'd go so far as to say it's a symptom of a much more complex picture. So it's the end result of the outcome. So the really interesting question about the missing data problem is, what does the missing data problem tell us about a lot of the things that Daphne spoke through? So she spoke about the importance of a trustworthy approach to data governance and data collection. She spoke about the importance of identifying clear barriers when it comes to data governance and data collection. The term hard to reach was challenged, rightly so. Again, I think there's something interesting there about how hard to reach situates the problem with the communities rather than the problem with the systems and the structure. And therefore, simple questions such as, are we collecting data in the right languages? Have we designed the data collection system in a way that enables people to access and participate equally or fairly? I'll just give you an example. Somebody reached out to me to participate in a South Asian biobank recently, and I with the best of intentions, I wanted to do that, but it's still at the very bottom of my to-do list. I'm not sure what that says about me, but if I'm still waiting to participate in the South Asian biobank, I think many of my colleagues and peers probably would be struggling to do so at the moment as well. So there's all these considerations to think through, and at the moment, participating in a biobank, for example, is quite a complicated thing to do. Still, requires going through a number of hoops, requires the impacted communities to participate, often without really little incentive to do so. So that's just a kind of really practical example, I think, of this point, which is the missing data problem is certainly a symptom of these structural challenges, and some my efforts to sort of put some flesh on the bones of what do we mean when we're talking structural challenges. We're talking about time, we're talking about money, we're talking about access here. And we're talking about who's expected to go where. And that's a really important question to think about and consider. One of the things I thought was quite striking about the report was this point about what an anti-racist approach to data collection looks like. I think there's just so much more work to be done in that space. But certainly thinking about that point which Daphne mentioned about overlapping oppression and intersectionalities, I think kind of is one way of describing this, overlapping challenges. But when someone is asked to participate in a biobank, I'm just using this as an example, it's not just their ethnicity that may be the reason for why they're struggling to participate. They may be experiencing you know, a multiplicity of life circumstances, and these all stack up on top of each other. So it is really about, you know, designing these systems in ways that make it as easy as possible for people to participate. And I think I'm just going to end on a note that I think that good data systems are a result of trust and trustworthiness. And the other question for us to address and answer is the missing data problem implies in part that the solution is complete data. And so the question that I've got here is, how complete should these data sets be? Now, what's good and in particular, what's good enough? So is that something that can be co-produced and negotiated with these communities, rather than getting to a point where we're developing data systems that aim to collect every single data point about every individual? So those are a few provocations there, building out from what Winston said.
Brilliant. Thank you so much, Rima. You've given us an awful, a lot to think about when we're thinking about, how complete is a good data set, or how good does the data set need to be? Because I think that there's certainly some data I absolutely don't want to have to share with the health system. So I think negotiating it is certainly a good idea. And I guess the question is how to do that in the most kind of effective and equitable way. And I kind of really like what you were saying around kind of trust being an important part of when we're thinking about how we go about kind of collecting data and using data in a way that can address inequalities. And I really wanted to pick up with Stephen. So I wonder if you could also introduce yourself, Stephen, but again, share your reflections on the report. But I'd be particularly interested in your reflections on trust and how institutions build trust with communities.
Okay, my name's Stephen Quashie, and I'm not really part of the health service at all. I've just been kind of whisked in to look at the research towards the back end of it before the report got written. And I'm a carer, so I care for my mum who has severe dementia, and so I've been exposed to the health service in lots of different capacities. I also support LGBTQ people over 50, so I have some insights from that point of view as well in terms of my part-time job. I think trust is really, really important. But one of the things that I have around this, coming from totally outside of the health system, is this word data, because for me, even that can be alienated just using the word. I want to get your data. Data is, for me, is what happens in the system. I was listening to a Spotify song the other day and it really moved me to tears. Now that's data, but I experience it as a song. So the information that goes in is my story. You want my story, you want my information. The information that comes out the other end of the system is analysis, is evidence, is patterns, is all that kind of stuff. So data for me is the stuff in the system. And so when we are talking to people, if we're saying to them, let's get your story, let's understand it, that's a significant point of actually people do like to talk about themselves most of the time. So for me, looking at the issue of narrative and storytelling is really important, because what we have is kind of this interplay between the story that somebody has about themselves, subject to the stories and the kind of resources of narrative around Blackness, around Asianness, and so forth. And often we battle against those to evidence our own story. And then on the flip side, it's the trust issue, is kind of thinking about how that story can be used against me, to discriminate against me, to alienate me, to justify their position. oh, he's only saying that because he told us this, he had some mental health issues and this is why he's making this complaint. It's a mental health thing or whatever it is. So the whole issue of trust means that we need to really think around how do we take person-centered approaches to healthcare. And obviously that's the direction of travel. And I actually don't think that the NHS have really told their story yet about why we're going down this route. It's not clear enough. It's not simple enough. It doesn't. We don't show the benefits of how we collect data and setting it within that context of all these other narratives that are drawn upon that marginalize us as Black and Asian people in the system, and the assumptions that come that we have to spend our time trying to, you know, almost presenting ourselves to say, actually, I'm not part of that stereotype. The stereotype doesn't apply to me. I want you to treat me as a human being. And we come to these conversations with some of those issues in play. So building trust means that you have to deal with the nuance of all of those different things, all those discursive processes going on, even within a simple conversation of how old you are.
Thank you, Stephen. Yeah, I think, you know, you've made some really hard-hitting points there, which I think that, and I think a lot of the time when you work in the health system, you perhaps don't necessarily think about really, because you're thinking about like the numbers. I need you to fill this form in, right? But actually, it's you know, but we're human beings. We have stories. And, you know, once you've let go of your data, then what control do you have over how your experience is interpreted and how that can also potentially be weaponized to your own detriment, so and to your community. And these are some of the things that also kind of surfaced, you know, through the report as what, you know, through the research that we did as well. So thank you for that. And I'd like to move on to Sabrina. So, you know, we've heard, you know, quite a bit around like the importance for, you know, Black and South Asian people to be seen in data, but, you know, it's not going to be the golden, you know, or the silver bullet that's going to, you know, completely transform inequalities, but being an important part of that. And that as much as the data is important, we also need to think about the human being behind that and how communities can have control over that narrative and shaping that. And so I suppose considering those things, I'd be interested in terms of your perspective, how that could be kind of operationalized, how you know, what are the opportunities and the potential challenges for you as somebody who manages services?
Great, thanks, Natalie, and really good question. So hi, everybody. My name's Sabrina Phillips. I am the Lambert Living Well Network Alliance Director, and essentially that means we work in partnership with statutory, so local authority, NHS Trust, and voluntary care sector partners to deliver mental health services in Lambeth. So really good discussion and really eye-opening things in the report. And I guess one of the quotes I'll start with, think about the opportunities, is how do we as a healthcare service make ourselves more trustworthy? Because it's interesting to see that there's something about the NHS, or whether that's local authority and VCS, that people are willing to give information to get some support. So thinking in terms of opportunity, there's something about how we support our staff to understand why they need to collect certain information, what's going to be done with that information, but also how do we play that information back to them to support their day-to-day work? Because some of the narrative is people put information into a system and you never see it again. The other bit is around how, and the bit is that control for me, because there's a bit around staff, and I think we need to start not only when the person starts work within our organisation, but maybe in the training. So moving further upstream. And I see there was a question there about upskilling, because if we do that, people are able to have those important conversations about, why do you need to know my ethnicity? Why do you need to know where I'm born? What is going to happen with that information? And also making it okay if people don't want to share that information and giving them space to do that at different times. But also there's something about how we work with our communities to understand what we do with their data, but more importantly, how we're using it to help them. Because I think there's something around giving people greater control over what information they share with us and what information they don't share, but also having those opportunities later on to update that as and when they see fit, which I think came out in the report as well, as we become more trustworthy to people that we work with. The other thing I thought, in terms of some of the challenges, before I go to the challenges, one of the things I think as a service director is being able to understand where the needs are in the community that we serve. I'm thinking Lambeth on a whole, so that we're able to put the needed resources in to help to reduce the inequality that we know Black people especially who have mental health problems are facing. Some of the challenges are, we do know we've got workforce shortages, so that's across our different organisations. And if we're going to be supporting people with training, we know we do have lots of short-term staff coming in. Since I think if we're training people from the off, that might help. So if people are covering in different parts of the organisation, there was thoughts around the IT systems that we use, and we do know a lot of it aren't fit for purpose. And when I say that, I think if I think about clinicians and the things that they need to input and having to wait for a computer to upload or identify who you are, people just don't have the time to do that. So how do we make the systems easier for people, not only for staff to access, but if we're going to give our people that uses our services the access, how do we make it more accessible for them? But also on the other hand, we need to think not everybody has access to data if we think about inequalities and data poverty. And the last bit is around time. So how do we ensure that people have enough time to do the practical things as well as gathering the information, but also ensuring that we enable people to share their stories, because people mention they're humans, they're not numbers, and doing it in a way that people don't have to repeat themselves several times. So I think my takeaway point is, how do I support people to make it easy for them to share the information that they need to share, but that it's meaningful for them, and that's both for the staff but also for the communities that we serve. Thanks, Natalie.
Thank you, Sabrina. So again, yes, you've kind of, it's like you've provided a really kind of pragmatic sort of like response in terms of like trying to balance the ambition of the work that you can do, but also the kind of realities of the challenges that you face in terms of delivering a service. So I want to thank all of our panelists for your thoughts, and I'd really like to open it up to people who joined. If you have any kind of reflections or questions for our panelists, we have about 10-15 minutes for questions. So if I hand over to you, Joriam.
Yeah, let me take the word here real quick. Folks, the way we normally do that is using the raise hand function on Zoom, which is under the reactions button you see at the bottom of your screen. It's just an organized way to do that. And let me kick this off, inviting two people. First of all, April, you asked a question a couple of minutes ago. If you'd like to say a question out loud, you could kick us off. So Azar asked the question, but they also sent me a little note saying, like, can you say this? Because I'm in a busy hospital. So this can be the second. Avery, would you like to start?
Yes, my name is Avril. I work for Public Health Scotland, and I'm currently doing work and focus groups around creating resources for frontline health staff to ask about all sort of equalities and the 9 protected characteristics. And I suppose some of the questions I've been wrestling with is, it's okay, we'll collect this information. And again, even how we collect that in a practical level with IT systems is an issue. But the big question for me is, once we've got it, what are we going to do with it? And how is it practically going to be used to improve services? You know, because if we don't use the data, we'll stop collecting it eventually because we don't need it, because we're not using it. And I want the information that we, and the data and the stories that we collect about people and all their intersections to be able to be used to improve their experience of health. Not sure if that was a question or a statement there, but that's what I'd be interested in hearing any views on.
Can I come in on that? Yes, I just think that's a really interesting point, because it connects to a few other things that have come up. But one of the interesting angles is clarity about why and how a data point or data set is going to be used, and making sure that there is that clarity so that it can then be communicated about in a really compelling way. That was a really key theme that came up in the discussion from Stephen. And then being able to negotiate that conversation. And sadly, in the development of data systems, those conversations don't get negotiated. I mean, it's not very common for developers of data systems to co-produce data systems with impacted communities. I think there's a lot of potential in this space. So I did write a whole report on participatory data stewardship, but actually I was quite surprised by how little there was. And so there is a sort of interesting power dynamic there. But I do think it starts from clarity of purpose and use. Like, how do we start with that? And then how do we then involve people in helping to ensure that it does work for the purposes it's intended to work? And then how do you understand the impact, its effectiveness? And what often happens is you see things happen the other way around. The data points get collected, but it's not clear really what the use is for the data points. And that seems to be an extraordinary waste of resources to some extent. That you've got data sets curated and collected, but it's not always been optimized to the best possible use and purpose.
Winston and Natalie, I'm about to introduce a new topic. Would you folks like to chip in on this question now? If so, I think you should just go ahead.
All I was going to say was that the data collection is of no use, as the questioner said, unless it's analysed and then shared and used to initiate conversations and training. One of the things I noticed in the report was this idea of some staff having a lack of professional curiosity, and it's partly because sometimes they can't see how does this data relate to the service they provide. So you use the data, you analyze, and you share it. You have to share it. You have to let people know and have conversations about it. That's how it's going to be effective. If you just keep it to those people who work with it, it's not going to. You'll have to share it with the people on the front line, even including patients as well. Yeah, that's all I wanted to say.
Yeah, and I suppose I also wanted to sort of pick up on even when the purpose and there is clarity about why data is being collected, and one of the things that we also found that in particular around ethnicity data, actually some members of staff don't feel comfortable asking people about their ethnicity because they have concerns that they may be perceived as being racist and may offend people from Black and South Asian backgrounds. So I think one of the other things that, as well as if we are kind of trying to encourage staff to have conversations with people about equalities and information relating to protected characteristics, we need to make sure that people also have an understanding of like what that means, the nuances, you know, and having that kind of cultural and racial capability to be able to hold those conversations and be confident to do so.
Cool. Let's move in then to the next topic. It's a question from Azar. who says, does anyone have any recommendations for how to design systems with intersectionality in mind? Everyone's lives are unique, and a multiplicity of disadvantage may not always be obvious. Systems need to ask the right questions to be able to develop truly impactful service. Therefore, alongside ethnicity, what other undeserved groups should be the quote-unquote most important?
That's a really tough question. Who's taking this one?
Well, in a lot of areas I've been in, whether it's in higher education or in health inequalities, I don't want to sort of push back at, but sometimes you just you do have to just focus on the biggest inequality, which tends to be around race and ethnicity. And yes, there are other intersections that impact on it, but what one normally finds is that when you remove these factors, again, think of the COVID data, when they removed all the other factors, whether it's where you live and all these other kind of things, there was still on top of this inequality based purely on racial and ethnic groups. So sometimes you do have to just drill down to race and ethnicity. Yes, there are intersections, but even when you can take those away, and you're still left with this situation. I don't know if I've answered the question, but that's how I would see it and want to answer it.
Yeah, and I think that, and I think in terms of, in particular, when we're thinking about using an intersectional, approach, I think that it's not something that we commonly use, and some of the challenges are that sometimes when you start to then look at people who experience multiple oppressions, actually, from a statistical perspective, the sample sizes become quite small. And so it can be quite difficult to have like a meaningful analysis of what you're looking for as statistical significance. And so I think that then that's also where it's important to think about how you surface challenges qualitatively. So around the story, so kind of when you're looking at your data, thinking about who isn't represented in that, in that data set. And so you might then have to adopt different approaches to surface the intelligence that you need in order to help inform, service provision, for example.
Hi, Natalie.
Hi, Professor Morgan, how are you?
I'm not cheering. I just saw your hand and I saw your face and I thought.
Always a pleasure. So thank you for the session. I guess a question in terms of the process and some of the conversations that I've been party to with regards to engagement, community engagement, data capture, and that's around, we often seem to start from A. So we're in lots of different contexts, the data capture, we need to know, we need to find out, we need to have more information. But what we don't seem to do as much of is maybe talking about what we do with the data, what the outcome has been of this data capture. And perhaps we need to kind of move a bit further down the alphabet in terms of saying, okay, so we've done this data capture exercise, this is what you've told us, and this is what we've done with the information. And I think as individuals who are problematized, I can't believe I said that word, but I have, as always being the reason why things are going wrong or the reason why we're not getting access to services, perhaps if there was a greater focus on what happens with the information that is shared, people would be more encouraged to do more of the sharing. So maybe we kind of need to move on a little bit in terms of, yes, there's lots of data capture and this is why the data capturing is important, but as somebody who is sharing their story, and I love that, that way of putting it, what we don't often have is the completing of that circle, which then comes back to, you told us and this is what we've done. Are there any thoughts around how organisations or groups can start to encourage service providers to do more of that bit of them telling their story? Thanks.
Thank you, Natalie.
Jump in really quickly, Natalie, on that, and Natalie thought that I totally agree with you. I think there's something about, and I think people have said it, we don't need to wait until we've got a complete data set. I think start with some of the data you've collected, share it, because that starts the conversations about what is missing, but what can we do about what we know now, so that we then can then go back to people and said, you've told us this is what we did we get it right? Is there more we need to do? Is there other questions we need to ask? So I think that's, so in the where I work, we have started looking at our ethnicity data, and it brings up lots more questions, which means we have to go back to staff to think about what else do we need to put in, or where we might get that from. But that's what data should do. It should start the conversation. It shouldn't be the end.
Yeah, absolutely. Thank you, Sabrina. Stephen, you wanted to come in here?
Yeah, I was just going to say that the whole issue of data only makes sense if it's put within a learning framework. And one of the challenges for the NHS at all its different levels is getting people to begin to work learning effectively, which is about critical reflection. It's about looking at what you do, being honest about the mistakes that you're making, or the things that you're getting wrong, as well as the things that you're getting right, and using the evidence that is gathered to interrogate your experience, whether that's been at a practitioner level, a management level, or whatever. And often what happens is that the learning framework goes out the way because it means accountability. We're so busy protecting ourselves from accountability in terms of being sued and so forth. We need to actually assert a learning framework as a very much part of that. And one of the kinds of things that's really important to do with this is actually say, okay, this is a discourse, and it's a discourse in many discourses, and there's a whole discourse around racism, about what's allowed to be said, what isn't allowed to be said. One of the things around professionalism is class. It's a big issue within the health service, and so that intersectionality of class and race and so forth all impact on each other. It's not just a separate thing, and so we need to have a learning framework that runs deep, and it's not just about the surface targets, but actually about intention, about feelings, about knowledge base, about the pools of assumptions that we're drawing from, and we have to bring those all into the frame.
Thank you, Stephen. So if I take, is it Neem and Rima, and then we're going to have to wrap up soon. So
yeah, I can be really quick. I just wanted to kind of respond to what Natalie says and said there, and a bit of what Stephen said as well. We did I'm part of Clearview Research, and we did the sort of first phase of this research where we spoke to people about how they felt about sharing their data. And that what you spoke about there, Natalie, came up quite a lot, is about like what for. So, that actually, that feedback loop, that actually not just extracting data, actually doing this together, where it's actually, this is why we're collecting it. And once we've collected it, what we find out, we'll also tell you, so that we're all in the next steps together as well. Came out of our research as being super important. And I mean, when you think about it, it's a bit of a no-brainer, but it's, that's there, and that's hugely important. And I think that's important at even the level of the first conversation about, can you provide me with your name and address? Why? So I think, yeah, that's massive. So I just wanted to kind of say that we've identified that as well, and it's definitely key to this conversation. So thank you.
Thank you. Yeah, and Rima.
Yes, it was a final point, which was about the diversity of the people designing and using the data system. So we've spoken a lot about people from ethnic minority background, Black and South Asian community being the subject of data system. But I just wonder when there's an assumption there that they may not be developing, designing, deploying their data systems. So let's just push on that assumption a bit. is my question. And also, I think there's some really interesting work that's happened in New Zealand in particular, and in Canada, where Indigenous communities have designed and developed their own data banks and co-produce that around genomics data in particular, which is a particularly contested term. So lots of international best practice to learn from there as well.
Brilliant, thank you, Rima. I think the discussion that we've had and the questions that have surfaced, I feel like we could probably spend a few more hours kind of putting the world to rights in relation to data, and perhaps, you know, that's something that we hope that we'll be able to kind of continue to carry on the conversation. So we will be launching the report shortly. So everybody who is on the who's registered for the session will be provided with a link to the report. And we're also going to be, we've also been co-designing some resources for healthcare workers and people who are NHS leaders and who work in policy around how they can have meaningful conversations with communities, but also what structural changes they need to put in place in order to make it much easier for us to be able to kind of address the gaps in patient data, but I suppose more importantly, how we kind of act upon it in terms of reducing inequalities for Black and South Asian communities and other racially minoritized groups. So if you want to stay in kind of contact, I would say definitely keep an eye out and add to your favorites the Understanding Patient Data team website, and we will drop that in the chat, but also we'll make sure that we send that to you. Also, don't forget to follow them on Twitter at Patient Data. And similarly, if you're interested in some of the work that we're doing at Liberating Knowledge, you can also follow us on at Liberating K on Twitter. No website at the moment, but that should be coming soon. But before we go, and before I kind of thank everybody, it would be great if everybody could put something in the chat, either it being something that you've taken away or an action that you're going to take forward in order to address the kind of inequalities and inequities in data collection for Black and South Asian communities, because it'd be really interesting for us to understand, you know, how this conversation may have inspired you to make a change. And while you're doing that, I would like to thank Emily and Rebecca for kind of working with us and kind of taking on this project. I think it's so important, in particular, because often when we're thinking about gaps in patient data, you know, Black and South Asian people are kind of often seen as the problem because we're so hard to reach. But actually, I think by kind of creating space for this work, it's kind of shown that actually it's a bit more complex than that. And actually there are things that we can be doing quite practical things that we could be doing to address these issues. And I'd like to thank all of my panelists, or our panelists, for sharing your wisdom with us. And I think it would be great to kind of find a way of kind of continuing this conversation. And also, as I said, keep an eye out for a series of blogs that will be coming out. So Understanding Patient Data team will be also sharing a blog shortly. So do keep an eye out for that. And I understand that this recording will also be shared. So again, have another watch and don't forget to share it through your networks. And I've done pretty bad, not too badly, 2 minutes over time.
Must be some sort of record. Folks, everyone will receive a follow-up email to this session with the recording and the slides. Thanks very much for being here. Thanks, Natalie, and everyone who participated. This has been an amazing session. Thank you so much.